Thanks, Dr. Shea Gregg, for talking to us about trauma in the elderly. Tell me about trauma in the elderly.
Hi, Chris. I thank you for having me here today. I'm very excited actually to talk about this topic because, quite honestly, we are standing on the edge of an epidemic. It's interesting. Trauma surgeons for years have quoted the 1 to 44 age demographic, where we say, trauma is the leading number one cause of death and morbidity in this age group, this population 1 to 44. Interestingly, rates that are affecting that demographic of trauma are going down. However, when you look at the age demographic over the age of 65, they're actually going up. And we're seeing people living longer. We're seeing people who are, life expectancies seem to be going up as well because, we're trying to preserve ourselves a little bit better. However, when that happens, due to comorbid diseases and a variety of other things, there's incidences of trauma that are actually increasing in the elderly population in that over 65 demographic.
Interesting. So
Yes.
how does trauma present in the elderly differently from a younger population?
So when you look at actually the primary causes of trauma, when you look at under the age of 65, some of the most common causes of trauma are things like poisoning, motor vehicle crashes, homicidal and suicidal violence. In the elderly population, the number one cause, falls. Either gravity is getting stronger, which it's not, or the bottom line is people are falling. And that is the number one cause actually of death in the age demographic over the age of 65 from an injury cause. Motor vehicle is the second most common, and then the other suicidal actually ideation is another reason for trauma in that population. So the mechanisms are different. And when you have these different types of mechanisms, you have to look for different types of injury patterns. If fall is the most common, then when you add fall on anticoagulation, which happens to be our most common thing that we see in our trauma center, then you actually, 1 in 10 will have significant head bleeds that are actually life-threatening all of a sudden.
1 in 10, wow.
1 in 10 for significant head bleeds who are on anticoagulation. Then you have your hip fractures, you have your extremity orthopedic trauma, you have rib fractures. And then when you compare the two demographics, the younger versus the older, the studies are out there that basically show that the morbidity actually is much higher and the mortality is much higher. So for a given number of rib fractures, if you're under the age of 65, some under the age of 45, you'll have, maybe upwards of 10% mortality. You go over the age of 65, then all of a sudden your mortality goes up drastically, 25% and up, just for isolated rib fractures, multiple rib fractures. Mm-hmm. So it's also been described that you have increased mortality with hip fractures. So you combine some comorbid disease, atrial fib, anticoagulation, osteoporosis, blood pressure swings due to being on blood pressure medications, you fall, and all of a sudden you have all these other problems and these injury patterns that you got to look for and maintain that high incidence of suspicion. And you got to find them and make sure you treat them aggressively. Get them to the higher levels of care, namely ICA and ICU level of care. Make sure they get good pain control that are non-narcotics. You try to use other types of pain medications and make those diagnoses early and treat them as aggressively as possible. And get them independent.
Mm-hmm. And so you went over a lot of the stuff right there in terms of the confounding medications and comorbidities. But are there certain things that you try to teach your residents about management of the elderly that's different from a younger population on a day-to-day basis when you walk in on rounds? Say, don't forget.
Actually, that's a great question. And the answer is absolutely. Taking care of geriatric patients require an entire team. All right. So not only do we educate the residents, but our geriatricians educate the residents, our physical therapists educate the residents, and there's a lot to learn about this population. And things like med reconciliation, is a very important aspect of things. When you go through someone's medications over the age of 65, and you're seeing that they are on either multiple narcotics for chronic back pain or hip pain or whatever, or they're on sleeping medications, Ambien, Benadryl. They're on a variety of other antihypertensive medications that are newly started out. These are all things that could actually have contributed to the traumatic event to begin with. The ultimate question, too, when these folks, when those who say have atrial fibrillation, they need to get that risk stratification after a fall of whether or not they should be on that anticoagulant, because if they don't, and say they have a low risk of stroke for atrial fibrillation, namely a low CHAD score or low CHAD vascular, which is a scoring system to determine your risk of stroke and atrial fibrillation. I really encourage residents to go through that as a mental exercise to really ask the question, well, this person has had 3 falls in the last month. We need to really ask the question, should they be on anticoagulation, and then get that feedback to the primary care, the cardiologist, etc. So approaching it from risk stratification and need of these medications, one thing we teach residents, but also protocolization. We can get these patients through the hospital a lot more efficiently, and we can make and if they meet criteria for admission or observation, now that we use nowadays, we want to get those physical therapists in there, we want to get the geriatricians in there, home safety evaluations in there, and we want to get them into their home environment or in their the rehabilitation environment, so we can possibly reduce their delirium, their confusion, etc. These are things that we're learning about this population as we go. More and more research is coming out.
Yeah, and your special interest and your institution, you alluded to the team approach. Can you talk a bit about what your institution in particular is doing?
Absolutely. So we saw that there was about a 350% increase in our elderly population that has come to this trauma center. And I practice at a very busy inner trauma center. But our population that has grown the most over the last 10 years is the elderly over 65 population. That being said, we created this concept of a geriatric injury institute where we use the trauma model, namely prevention, pre-hospital care, seamless transfer into in-hospital care, and reintegration into society. And we brought leadership together in geriatrics, the emergency department, a variety of departments, primary care, and by using the trauma model and actually building up care pathways, protocols, preventions, and also philanthropy too, who has actually been very interested in supporting our mission of this institute. We are able to actually, I think, deliver a more efficient care model to these patients right when they hit the door and even before they fall. And this concept of building an institute, it's multidisciplinary, it's collaborative, and we have great buy-in and support from all levels of the institution. So we're trying that as a model here. We're doing some more research. We have some more projects and databases that we've built up, and I can't wait to get it out. So get these reports out so people can really understand the benefits of what a multidisciplinary approach can do.
Tell me a bit more about reintegration and how this population is different from a younger population.
Absolutely. So what we found is that in that population that falls, about 70% of our patients who are on anticoagulation, we have a database that we run, about 70% of that population that falls, about 50% of them actually end up in some sort of an extended care or a rehab facility, which is interesting because this is a sicker population, and the other 50% will go home, but they'll usually have some sort of VNA services. So ultimately, our goal from a geriatric injury institute standpoint is to get people back to independent living to the best of their abilities. People want to go and drive their car to church. They want to go shopping. They want to see their family members. They want to have that independent living. It's our goal to make sure that if they do have these events, is to maximize their physical therapy, their ability to reduce falls through exercise programs in the community that we are now setting up. Tai Chi has actually been shown to reduce fall incidences in the community. Other certain exercise programs. And the bottom line is not only is it just a matter of getting them out of the hospital into a facility, It's a matter of getting them out of the hospital into programs that will keep them out of the hospital.
Sure.
It's population health, it's community paramedicine might play a role. That's where we're going with this.
Interesting. Final thoughts on injuries in the elderly?
We have a lot to do. We really do. And this is a population that for all these years, we've definitely focused on that 1 to 44 demographic. And I think there's a lot to learn. I think there's a lot that we can do for this population, because quite honestly, we're going to be there very shortly, you know. And hopefully they'll be able to take care of us in the way that we hopefully blaze the path to allow them to do so. So I'm looking forward to working on these projects, and I thank you for letting me speak with you about this.
Oh, thanks for taking the time, Dr. Gregg. Take care.
Thank you.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.